Urodynamic and clinical features in women with overactive bladder when to suspect concomitant voiding dysfunction. There's nothing to disclose. Female voiding dysfunction is defined as an abnormally slow or incomplete micturition. Coexisting voiding dysfunction in patients with overactive bladder has been described in up to 50%. Voiding dysfunction may be caused by either bladder outlet obstruction or Detrusor underactivity. Our goal was to describe the prevalence of voiding dysfunction in the OAB population submitted to Urodynamics, and to look for some predictors of this alteration. We reviewed all the urodynamics performed in our university hospital from 2015 and included all women with OAB and excluded those with incontinence surgery, high-grade prolapse, neurogenic bladder, bladder pain syndrome, radical pelvic surgery, and patients without a flow pressure study. Urodynamics were conducted by the ICS standards, and every subject had a structured interview beforehand. Obstruction was defined when female bladder outlet obstruction index described by Solomon-Greenwell was higher than 18. And underactivity was defined when all of these criteria were met. Qmax less than 15, the Detrusor pressure at Qmax less than 20, and residuals higher than 10%. 299 cases were selected with a mean age of 55 years. 30 had hypertension, 14 was diabetic. Most of the patients had mixed urinary incontinence. They used a median of 3 pads a day and a median of 8 and 2 micturitions a day and night respectively. Using the described criteria, we found that 20% of the patients were obstructed and 3% had the Detrusor underactivity. When assessing the voiding symptoms, around 50% of patients complained of any voiding symptom. The most common was incomplete emptying. The proportion of symptoms was not correlated to either obstruction nor underactivity. We looked whether any clinical features was related to voiding dysfunction, and we found that obstructed patients had a median 9-time frequency that was statistically higher than the controls, and the underactive patients had higher proportions of hypertension and a higher daytime frequency. Age, diabetes, and number of pads a day were similar among groups. Regarding the urodynamic features, obstructed patients had a smaller systometric capacity, a higher proportion of the Detrusor overactivity, a smaller voided volume, and a higher PVR. On the other hand, underactive Detrusor patients had only a smaller voided volume. Taking the features that were related to obstruction in the bivariate analysis, we performed a logistic regression that showed that 9-time frequency, presence of the Detrusor underactivity, and PVR were independent predictors of obstruction. Whereas for the Detrusor underactivity, only a small voided volume remains statistically associated to the Detrusor underactivity in the multivariate analysis. There is an important selection bias when we analyze only the OAB patients that were actually submitted to a urodynamic. Most of the patients had mixed urinary incontinence, hence a presumably low resistance bladder outlet. This could underestimate the true prevalence of bladder outlet obstruction in the whole OAB female population. Due to small numbers of the Detrusor underactivity patients, it is difficult to find proper predictors. Female voiding dysfunction prevalence in OAB patients seems to be remarkable. Voiding symptoms are not able to predict the presence of female voiding dysfunction, but some clinical features like a really high daytime frequency and a low voided volume, and some urodynamic features like systometric capacity and the Detrusor overactivity should make us wary about the existence of female voiding dysfunction.